Hey everybody, welcome back to MedEd Insights, the channel dedicated to helping medical students and residents get through their medical school and training, as well as offering a little bit of insight and experience into the field of physical medicine and rehabilitation. For those who don't know me, my name is Brian and I'm a PGY2 in PM&R at Mayo Clinic in Rochester, Minnesota. I recently finished up my first rotation during my PM&R residency and I was on the inpatient brain injury service. And so in today's video, I want to discuss one of the cases that we saw in order to go over some of the details in terms of what we actually do as physiatrists, particularly when it comes to a patient with a traumatic brain injury. So for any medical students out there interested about PM&R, or for anybody who just wants to get a better sense of what it is that we do on a day-to-day basis for our patients, stick around for this video and we're going to talk about a specific case I saw on the brain injury service. So our patient was a middle-aged male who was brought into the hospital via EMS because he was involved in a motor vehicle collision. As a result of this accident, he sustained a traumatic brain injury with a subdural hematoma and scattered subarachnoid hemorrhage, as well as polytrauma with multiple fractures throughout his body that limited his ability to ambulate and perform physical activities. And so the first point here is, how would we classify this patient's traumatic brain injury? And to do that, we use the Glasgow Coma Scale, which, if you're not familiar, is a series of 3 different categories related to eye-opening response, verbal response, and motor response, and allows us to assess the severity of traumatic brain injury. This patient had a GCS of 12, which would classify him as having a moderate traumatic brain injury. Now, by the time we saw the patient, he had been in the hospital already for around 4 or 5 days, and so we didn't see much of the acute stuff as a result of his injury, but when he did come to the rehabilitation service, he had a lot of challenges in terms of symptoms that he was dealing with. In particular, he had really severe pain and headaches. And it was really not just kind of routine pain from fractures. It was really multimodal pain from both his traumatic brain injury, from his headaches, from his fractures, from abrasions on his skin that really impacted his function throughout the day. He also had significant urinary retention, which puts him certainly at risk of kidney injury as well as developing bladder infection. He had very poor sleep as a result of his brain injury, had a lot of trouble with confusion and becoming intermittently agitated at night, had significant balance impairment as a result of his traumatic brain injury, and of course had limited use of his extremities as a result of his multiple fractures. Because of all the pain medication that the patient had been getting previously, he was also very constipated and hadn't had a bowel movement in a number of days. So already off the bat, you can see that there's a lot of different things going on in this patient, and while you might think these are all really simple things that any internist can manage or any neurologist can manage, on their own they possibly could, but in the context of the traumatic brain injury patient, it really takes on a different shape and is much more challenging because it's not as cut and dry and you have to understand how all of these things are interacting with each other. So one of the first things I mentioned was pain, and pain can be very challenging in these patients, and everybody thinks that pain is really hard to manage, and it's true. But what's really tricky about some of these patients is what type of pain they're having. After a brain injury, the body understands and senses pain much differently, and depending on whether or not they're having headaches or pain from their fractures or their skin abrasions or neuropathic pain, you really have to look at the different modalities to help manage their pain effectively so that they can get through therapy. The unique specific thing about this patient was he was having what we would call post-traumatic headaches. And post-traumatic headaches are fairly common after a patient has had a brain injury, and it's exactly what the word said. It's headaches that are persistent after some sort of traumatic injury. And certainly you treat them based on if they seem similar to a migraine, you can treat them like a migraine, but there's some other specific medications that we use on the brain injury service to help manage these headaches. And the choice of medication really depends on what types of other issues and symptoms the patient is having. Whether or not they're having neuropathic pain, difficulties with sleep, or difficulties with autonomic dysfunction. There's different medications that you can use to prophylactically help their headaches rather than reactively treat their headaches. And in particular, in this gentleman, we used a medication called propranolol. And propranolol is often something we think of for the heart rate, but it can really be helpful in patients with traumatic brain injury to not only help prevent headaches, but to also help with autonomic dysfunction that can arise, leading to large fluctuations in blood pressure and heart rate. Another common thing after brain injury is bladder management. And typically because of the way that the bladder works, it's often that patients are having a lot of incontinence. But for our patient, it was the other way around, and there was a lot of urinary retention. to the point where when we first saw the patient, we were having to do intermittent catheterizations every so often because we didn't want the bladder volume to get too large. So what we'll do is we'll do routine bladder scans after we've encouraged the patient to void in order to determine how much urine is in the bladder. If it's greater than a certain number, then we'll do an in and out catheterization to help relieve that pressure on the bladder. Agitation and sleep are two really common things that we run into in brain injury patients. And there's a whole lot of different classification systems for how we determine the severity in terms of how confused and agitated or inappropriate these patients are, but it's essentially a lack of inhibition on the brain. And so as a result of their injuries, the patients can be a lot more impulsive. They have a lot more energy, they have a harder time with tolerating a lot of stimulus, and they can just become very agitated and confused based on how severe and how far out from their injury they are. On the medicine services, if someone's acutely delirious and hurting themselves, oftentimes we resort to specific medications. But in brain injury patients, we have a lot of other things we try to do beforehand. We understand that with these patients, it's really just important that they're not a risk to themselves or to anybody else. And so a lot of times we'll just try to let them run off their steam. We'll let them go for walks supervised in the hallway. We'll push them around in the wheelchair at night. We'll do anything we can to safely help them get rid of that excess energy without having to give any medications. We really encourage the family and the providers to also try to limit the amount of stimulation that these patients are getting. So we'll limit the number of visitors that are coming to see the patient. We'll try to make sure that we're giving very clear, specific instructions, that we're not being too confusing. Limiting the amount of conversations that are going on in front of the patients can help. Limiting TV, screen time, all of those different things to try to minimize the amount of stimulation that the brain is getting will help with that agitation. Now, in a number of patients, we do have to resort to medications for a short time. And similar to when you're in internal medicine, there's a lot of different medications you can choose. But specifically in the population of brain injury patients, there are certain ones that we learn about that are more effective for healing. For example, haloperidol is one that theoretically can impair brain healing after traumatic brain injury. So while you might give that very commonly on the medicine floor, on the brain injury surface, we're trying to avoid those types of medications as much as possible in order to help not delay that recovery from the brain injury. And this is something similar that as our patients recover throughout their stay on the rehabilitation unit, it gets better and better to the point where we don't need to use those medications at night. And it's really a matter of how quickly the brain is recovering and healing from that brain injury that allows us to wean off of those medications and start doing a lot more conservative things as they recover and start to have more awareness and less agitation and confusion. One of the specific scales that we'll use sometimes to help describe how confused or agitated our patients are is something called the RACHOS Los AMIGOS score. And this is something that is more so used as a description for us to understand at what level these patients are in terms of how confused, inappropriate, or agitated they're at throughout their recovery. And it's something that we hope our patients will progress through during their recovery so that ultimately with each step they get better and better to the point where they're not as agitated or not as confused. And it's something we use a lot to the point where on sign out we'll say, hey, this person is a Los Amigos stage 4. And so to me, I know what that means when I hear it in terms of how that patient is going to be acting when I'm on call, so I can anticipate the types of stuff that I might run into while I'm taking care of them. One of the other common things that we use for post-brain injury patients is something called post-traumatic amnesia, and specifically the modified G.O.A.T scoring system. And so post-traumatic amnesia is exactly what it sounds like. It's a period of time that persists after a traumatic brain injury where the patient is amnestic, meaning they are unable to carry forward memories from one day to the next and don't have any memory of the accident itself. Post-traumatic amnesia, or PTA, is something that is used a lot of times to help determine prognosis in individuals after brain injury. But we also use it as a good indicator of when we feel like they're starting to improve whenever they're coming out of that period of PTA. And we do that by using something called the G.O.A.T, or in particular the modified G.O.A.T, which is a shorter scoring system. And it's basically a system of questions that we go through that help us understand how oriented, alert, and how much memory retention our patients are having. Once they've hit a certain score for a number of days in a row, that we can consider them to be out of post-traumatic amnesia, and overall indicates that they're hopefully starting to make some really good progress. One of the other big things that we worry about after a brain injury is seizures. And in particular, when a patient has had some sort of brain injury in an area that's highly sensitive to seizures, such as the temporal lobes, we really worry about seizure prevention. And so in this patient in particular, we had him on a medication to help prevent seizures because we know that they're at higher risk after a brain injury. So similar to the other medicines, it's important for us to understand the side effects of these different seizure medications in order to choose which one might be most effective or best to use in our patient given their other comorbidities and symptoms. A common electrolyte problem that can happen after a traumatic brain injury is something called cerebral salt wasting. And basically what happens is you'll notice your patient is starting to have large amounts of urine output, and they're basically wasting salt through their urine. And so we're routinely monitoring their urine output and occasionally checking electrolytes to make sure that they're not becoming hyponatremic, which can lead to even more problems with the brain as it's trying to heal. SIADH is also another really common thing that happens in patients with traumatic brain injury and stroke, and so that's another aspect of their care that we're responsible for as their physician while they're taking care of on rehab. So those are just a handful of the common medical things that we run into, and those were all things that we had to deal with on this particular patient. Certainly every single brain injury is a very different circumstance in terms of what specifically you're doing, and along the way there's a lot of family education and just family communication that you're having to have with your patient. Overall, it's really cool to see how much progress your patients will make, and by the end of the time they're with you, you can really start to see their personality come back out as they're improving from their brain injury. So it was really fun to kind of work with some of these patients and get to see the amount of progress that they were making as we were supporting them through their therapies and through their care. I definitely, at the end of these past couple months, have a much better understanding and appreciation of what our role is as the doctor on a team taking care of patients with traumatic brain injury. As always, thanks for watching these videos. I appreciate it. Feel free to subscribe. Let me know any comments below about any other questions you have in terms of what we do as a physiatrist on an inpatient brain injury service, and we'll see you guys next time. Bye.